Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. The cardiology seminars are brought to you by Triple N Media on our YouTube channel. We have more than 200 cardiology lectures. We welcome you to watch them at your leisure. We also kindly request you to subscribe to our YouTube channel and like our videos so we can keep you abreast of our latest additions to the cardiology lectures. I also have a cardiology rotations manual which contains 175 pages of pertinent information for nurses, medical students, residents, and for cardiology fellows to enhance their experience during cardiology rotations. I will tell you how you can get a free copy of this book at the end of this presentation. The feature presentation is sensitivity, specificity, positive predictive value, negative predictive value. How do we use that in a clinical scenario? I want to walk you through a hypothetical situation in a real clinical setup as how we can apply this phenomenon to improve our quality of medical service. Let's say a brand new cardiologist who has been in practice for a couple of years gets a letter from the hospital saying, we want to review your heart catheterization cases and look at your indications for the heart cath. Ooh, that's not good news. Or you may get a letter from Medicare saying that you are doing unnecessary procedures here and we want to review your charts. That's not good news either. So how do we try to figure out what we are doing is accurate, reliable, and predictable? In order to do that, we're going to take this hypothetical situation and find out where we are at the present time and see how we can improve the situation so that whatever we do is less harmful to the patient, provide very useful information, and minimize unnecessary procedures. Okay, let us begin. Let's say as a young budding cardiologist, you take 100 cases of patients who had a stress test, who also had a cardiac catheterization. And now we want to find out how many of them did really have a abnormal cardiac cath and also an abnormal stress test, or how many of them had normal coronaries but had abnormal stress tests. So let's begin. So here we put them into 4 boxes. That is, if the patient had coronary artery disease and had a positive stress test, we put them here. So there were 34 people who had coronary artery disease and the stress test, I correctly identified them as having abnormal stress test. So that's well and good. However, 6 patients who had coronary artery disease, the stress test was negative. How could it be? Well, maybe the patient didn't complete the stress test, had arthritis, obesity, couldn't finish the stress test. So there are any number of reasons where a patient with a heart disease could have a negative stress test. If they don't finish the test, it's worthless. So for the purpose of discussion, 6 people had a negative stress test. Or maybe they reached a target heart rate, but they had a negative stress test. But this doesn't help us. We want to find out if somebody has a heart disease, we expect like a majority of them, not 100%, but majority of them to be positive. But here we have, a significant number turning out to be negative. So that's not going to help us. So let's look at, okay, what about those people who had no heart disease? Yeah, normal heart. We know normal heart because they had normal coronary arteries by angiography. Okay? In the group with no heart disease, 10 of them had a positive stress test. It's called a false positive. How could it be they have a false positive? Well, we are relying on the electrocardiogram. Electrocardiogram is not a very reliable index of ischemic heart disease, especially in women. In women, up to 50% of the tests could be abnormal. They have STT changes all over the place, but it doesn't mean they have heart disease. Oh, so that's not good. So what are we going to do? How are we going to improvise our approach? Let's look at it. People who had no coronary artery disease had a negative stress test, and 50 of them had negative stress tests. That's a good number. So in other words, out of 60 people, 50 of them turned out to be correctly identified as having a negative stress test and a negative cardiac cath and no coronary artery disease. But these raw numbers won't help us to say, how am I doing? What do I need to do? How do I improve my predictive values? So in order to do that, we go to the next chart and we're going to say, how sensitive is the stress test? If you take 100 people with a cardiac cath proven coronary artery disease and you do a stress test on them, how many of them will have a positive test and how many of them may have inadequate or negative test? And that is determined by the sensitivity. Here, people who had heart disease, we had a total number of 40 people, out of which only 34 of them had a positive stress test. So the sensitivity, the ability of the stress test to identify coronary artery disease in patients who has documented coronary artery disease was 85%. That's pretty good, but still 15% of the time the stress test couldn't identify it. That means, is this number acceptable? Reasonably so, but can we improvise on that? That's going to be answered in the future. Now the specificity. Specificity refers to, okay, we take 100 people with normal hearts and do a stress test on them. How many of them will have a negative stress test that correlates with the normal angiographic findings? And how many of them have like false positive stress tests? Okay, here we had 60 people who had no coronary artery disease by angiography, out of which 45% of them had really negative stress tests. So the negative stress test predictive value is 75%. But you see, we are sort of behind in both sensitivity and specificity. We got 75% specificity. That means 25% of them can have few or false negative results. And this is not going to help. And if we keep continuing doing this, we may doing unnecessary procedures in patients with normal coronary arteries, or we may be doing unnecessary tests and missing out on people who really have coronary artery disease. In the previous slide, we looked at the sensitivity and specificity. Now we're going to look at two other parameters, namely positive predictive value. How effective is treadmill in predicting someone has a heart disease, in whom we know they have heart disease by cardiac catheterization? A positive stress test identified the presence of heart disease only in 69% of the patients. That's not a good number. You know, we want to improve this number because we could be missing out on almost a third of the patients. Same thing, negative predictive value, which is a little bit better. That means if the person has a normal heart disease and you do a stress test, and if it's negative, you know, it is 88% accurate in identifying those patients with normal heart disease. So since you're getting a letter from the hospital and from Medicare, so you call up your uncle who is the professor of cardiology who wrote the book on stress tests and say, "Uncle, I'm getting these results and I don't know. I'm getting letters from the hospital and Medicare, so what should I do? How can I improve my quality of care?" Otherwise, uncle says, "What kind of tests are you doing?" He said, "The regular treadmill test, that's all I can afford." What about the nuclear stress test? Well, the nuclear stress camera costs $300,000, so I can't afford to buy a camera right now. I just started my practice. Okay, why don't you select your patients, those who have low risk, young people, no significant symptoms, you do your stress test. Whereas those intermediate people with risk factors and things like that who are more likely to have heart problem, you do your nuclear stress test. So why don't you do that for a year and then take the same 100 people and see what the results are? Uncle, that's a great idea. Thank you so much, and I will get back to you in a year and tell you what the results are. So what you do is you try to combine the stress test with nuclear imaging. because you have the EKG changes. Now you are adding a second component, which is the nuclear imaging. So when you did that, now the numbers changed a little bit. You had 34 patients in the real heart disease patients who had a positive stress test, but the negative stress test came down to like 3 instead of, I think it was 6. Same thing here, which was like 15 people who had no history of heart disease, who had positive stress tests. The nuclear images were able to identify some of those. So the number dropped here, and the number of false positives, true negatives, came up. Now, if you look at the positive predictive value, which was 69%, has gone up to 89%. That means you're able to identify real heart patients with much more accuracy than what you were doing before. Similarly, you can identify now with the negative predictive value of the tests, combining a stress with nuclear imaging went up to 95%. So if the person has a normal heart and you do an EKG with the nuclear imaging, 95% of the time it can identify the absence of coronary artery disease or significant coronary artery disease. So this is a pretty good result. Now you call up your uncle and say, "Uncle, thanks for telling me. I combined the nuclear imaging and my sensitivity has gone up to 89%, and this is supposed to be specificity has gone up to 95%. I said, "That's good. Congratulations." So that's how you apply this in your own practice and see how you can constantly do quality improvement in whatever you do. It could be with medications for blood pressure control, or it could be doing tests, much more reasonable tests, which can give you even better results. So that's how you do it. Thank you so much for watching this presentation, and please watch the other 200 videos we have on cardiology playlist, and please also do subscribe to our YouTube channel. This cardiology seminar has been brought to you by Triple N Media, and please do subscribe to our YouTube channel. I will see you in the next video.